experience on perfusion optimization for critically ill patients. Before I introduce our speaker today, I want to run through some administrative stuff with you to ensure we have a smooth session. So the first thing I want to introduce you is that there is an option for you to turn on the subtitle for this session, which is on the bottom right corner of your screen. You do have an option to turn on Chinese or Japanese, but do realize it's an auto translation. I'm not sure about how accurate they are. I think they're getting better. We can always try it. The second thing I want to bring to your attention is that we welcome your questions throughout the session. Here is where you can submit it. You should be able to see this on the right-hand side of your screen. Then you can ask questions. You can submit questions throughout the session, and we do have a dedicated Q&A time at the end. The last thing I want to just walk you through today is that we will run a survey in the end. I'd like to do a quick try to make sure it works. You can take the survey by either scanning the QR code on your screen with your cell phone, or hey James, can we send out the link in the announcement so people can see? There should be an announcement link coming up that you can click on the link and answer the question. So we're curious to see how many of you who are here today, how much hemodynamic monitor you're currently using. Let's just give it a second for people to pop it out, the answers. Come on, don't be shy. If anybody has any trouble with the above three things, please push it into the Q&A box so we can see it. Alrighty then. We start to get some answers. All right, I think I'll stop here, but it looks like most of you are not using it on that much of your patient right now today, but it's kind of interesting to see how that's changing. Oh, no, now we got a few more people coming in with more. Wow. Alrighty. Thank you for the information. All right. With that, let me introduce. Thank you very much for your time. Great, thank you. Now let me introduce our moderator for today's session, Professor Shiji Ku from National Taiwan University Hospital, Department of Internal Medicine. His professional interests include internal medicine, pulmonary and critical care medicine, ultrasound in respiratory system, sleep disorder breathing, etc. Professor Ku, thank you for moderating this session. Please get us started.
Okay, thank you, Chia. And I'm today's moderator. I'm Dr. Ku, and I make a short description of today's session. First, our invited speaker will give a lecture about 45 minutes, and we left about 15 minutes for Q&A sections. So, during the presentation, if you have any question, as Gia mentioned, you can post your question in the Q&A box. Then we can see your question. Okay. So right now, I will introduce our distinguished speakers, Dr. Charles Hanley. Dr. Charles Hanley, he is the Director of Critical Care, Orlando Regional Medical Center. He's done extensive research in hemodynamic monitoring and perfusion optimization. His area of interest is resuscitation of critical ill patients. Then today's topic, he will talk about optimizing perfusion through hemodynamic monitoring. So let's welcome Dr. Charles Hunley.
You're muted.
Yeah, please, demuted the sound.
Hold on.
Okay.
Can you guys hear me now?
Yeah, we can hear you.
Excellent. That we practiced that and then it didn't do that. So good morning, everyone. Thank you for your time. And I'm very honored to be here talking to you all. Today is actually one of my favorite topics, and I'm going to talk a little bit about optimization of perfusion through hemodynamic monitoring and really talk to you about how it is important and some of the ideal states. My education disclosure is I do a lot of research and development for Edwards Life Science, and I'm very thankful for that. They allow me to practice my passion, and that's to develop technology that helps the patient care, and I'm indebted for them for that. My full disclosure is I'm really a geek. In the United States, we have this show called The Big Bang Theory, where Sheldon is this physicist, and he tries to act cool, but usually acts like, a little geeky. I'm trying to be the guy on the right, be like real Superman and talk about things. But really, to be honest with you, today we're really going to talk about a couple of objectives. And it's, we're going to basically review physiological principles. Most of us know this, so it's going to be very quick. But then we're going to use those hemodynamic and physiologic principles to when you need monitoring, how to escalate monitoring, and then review of just the hemodynamic principles before we go into devices and how they can help. And so without further ado, the real truth of physiology is that there is no normal cardiac output. And the question is whether it meets the metabolic demand. And with that being said, we want to make sure that hemodynamic monitoring is for individual patients and to adjust their physiology to improve their homeostasis state and then recover them in the ICU. And so really it's about the adequate demand versus consumption. Are we giving enough oxygen to the body through hemodynamics? And then what's our consumption? And we have many, balances to that. In the United States, we tend to focus on numbers, like cardiac output has to be 5 liters and 2.5 cardiac index. But to be honest with you, we really need to look at the balance of it and understand that not everybody needs hemodynamic monitoring. And this is one of my friends that put a paper out, Ciccone, and he basically said, hey, who needs hemodynamic monitoring and who doesn't? Not everybody needs it. If you think there's evidence of inadequate delivery of oxygenation and that you might be able to do something about it, and you might be able to manipulate the cardiac output, it's really important to consider learning how your interventions help or hurt the patient, and that's when you need cardiac monitoring. And basically, if you consider hemodynamic monitoring, if you can improve it, try to put it on and give your therapies an indication of positive or negative. And we're going to talk about that because there's many places, and some of my passion is to take hemodynamics in the ICU and the OR. It's very easy to wire our patients up. We have very, very invasive mechanisms, swans, arterial lines, arterial waveforms. But as we leave the space of the OR and the ICU, how do we able to monitor those patients? And can we monitor the cardiac output in a more non-invasive way? And so you ask yourself, where's the right spot? And then what's the most non-invasive way you need for these monitoring? And when I say that, I mean, not everybody needs a swan dance catheter, but now we're starting to see that advanced heart failure and cardiogenic shock, that might be a very good hemodynamic device to titrate right heart failure. Where in the ED, you might need just a simple arterial line, but you also need a way of understanding your therapies of giving fluid and pressors. And we're going to talk a little bit about that in the future. So it's not just one device fits all. It's what device gives you the best hemodynamic information at that event, and in that setting, whether it's the OR, the ICU, the floor in the United States, or in the ED. And so we're going to talk a little bit about how that hemodynamic monitoring. Really, in the world of hemodynamics, in the world of internal medicine, especially in the United States, we can't do a lecture without an ROC curve. And this is a classic 2008 model. And we're going to talk a little bit about this in the sense of practicality. And so basically, Maxime Cannison and his group came out with a statement that said pulse variability indexes, whether it's the PPV or the SVV, are much more user information higher on the ROC curve than a pulmonary wedge pressure or a central venous pressure. And so what they're trying to say really in today's day and age, and we're going to see how technology changes, is that the functionality of changes, momentary changes, and not giving a wedge every 6 hours. And you can use your therapies and manipulate them and see what their result is. And so my term for this is this a dynamic variable such as SVV and PPV? So when I give fluids or a change in stroke volume, I know what that change is over 3 minutes. Or is this a static where I'm looking at it as a picture every 6 hours? And that's actually very important when it comes to hemodynamics, because when we start talking about arterial waveform analysis, which is really a very incredible event, and as we develop our technologies, we're not just able to see the area under the curve, which we have always classically talked about the SVV, but we've also learned that we can understand the rise of pressure over time, which in the echo world, we call that DP-DT, right, which is the contractility. And then we can look at the deflection or the volume that's pushed over this pressure and give it a reflection of resistance, which we call dynamic elastance. And as we look at the mathematics that we can create now, we understand that we actually can look at not just, and you look down here, not just the pressure change and not just the volume, but we can also look at a deflection of resistance. And that gives us a dynamic event that we'll start talking about here in a second. And so when you look at the effects of stroke volume, you can look at in an arterial waveform the contractility, the SVV, and the dynamic elastance. Well, that has actually changed over the last few years greatly, because now we're not only understanding the preload, the afterload, and the contractility component in this, but we're also able to predict changes as we do an intervention, whether it's going to be beneficial or not, or we can predict things such as hypotension, which we'll talk about a little bit. And so what we're now looking at is that a cardiac output has, and an arterial waveform has the ability to look at three variables all at once in their interaction, depending upon your setting. This has actually been a kind of controversial over the last decade, because most people think that stroke volume variation is useless, and that if you're spontaneous breathing, if you are literally have arrhythmias, or if you have certain events such as open chest, that any arterial waveform is not really indicated. And so this actually is one of our papers in our group that we did when we actually looked at, can I have an arterial waveform, and is my arterial contractility the same as my left heart contractility? And what we did is put a gold tip catheter inside the left ventricle, and then we measured the arterial DPDT and compared it to it. And as you can see, most of our comparisons were right on, and it actually started to revolutionize that arterial wave functions have a direct reflection to cardiac performance wherever they are, whether they're femoral lines or arterial lines, which starts to give you the utilization that you can not only use stroke volume variation for a constant ventilated patient, but you can also use contractility, which is extremely important. And so when you start to assess dynamic parameters, we start to assess not just SVV, but we can also change the global of what does the stroke volume change. Are they fluid responsive? If I give a fluid response and the stroke volume changes greater than 10%, then we know that the patient's ability and the need is to give fluids. And if they don't change, then we know that they do not need fluid and we should go on to other events such as pressors. And we have now starting to do this, and you'll see actually a project that we did here in Orlando, looking at stroke volume for patients who are wide awake, breathing, and not intubated. And it actually benefited those patients for fluid analysis, which we can do anywhere on the floor, the ED, and in the ICU. When you start looking at stroke volume variation, you start looking at the indications of fluid responsiveness. And those are usually mechanically ventilated patients, but we also now have the ability to look at DPDT, which is the contractility component, and the dynamic elastance. This is a classic example of a patient that we have done on the floor, which basically, if you do a straight leg lift and you hold it up, and there's papers on that, so I want to make sure I don't belittle the time we have. But if it changes greater than 10%, we know that they most likely are fluid responsive and that they need to get more fluid. And if they do not, then basically do not give them any fluid. They're beyond the curve right down here and the top of the curve, and more fluid will be detrimental to them. Same thing on the other side of stroke volume variation, just like I talked about before, is the variation is extremely important when these mechanically ventilated patients. But now, as we're starting to develop our technology, and Edwards has HPI, which is hypotension predictive index, we're allowed to separate those contractility, stroke volume variation, and dynamic elastance to look at the reflection of preload, afterload, and contractility. So stroke volume optimization, just like I talked about, I kind of already went over the slide, is extremely important. This setting of this is one of my favorites because I can do it non-invasively with something like a clear site, which is one of my big passions, is to take a clear site to the ED and take the clear site to the floors and be able to give them fluids and not give them too much fluids, but not under-resuscitate those patients, such as in septic shock or patients who come in other types of shock. And so we're able to optimize their fluid management without having to just guesstimate, which we all know is about 50% accurate. There are limits to stroke, to arterial waveforms. Those limits basically we know, and we just kind of talked about those limitations of SVV and PPV and PVI, is basically, are you spontaneous breathing? It could give you a false indicator, but now we're starting to utilize contractility a little bit now, and that kind of supersedes it. And open chest, there's an issue with just the compliance of the arterials and the aorta with that, and most hemodynamic monitoring errs on that. And low tidal volumes, abdominal pressures, high heart rates tend to have a problem with that. And then basically, if you have right heart failure, which we'll talk about a little bit later, you have a ventricle dyssynchrony. So your left and right don't work right, so you don't understand how that fluid movement occurs. This algorithm, basically, I like to put in here. This is actually, and I'm not sure Edwards has this algorithm on their book anymore, but it really kind of breaks it down to say, is the patient intubated or are they not intubated? If they're not intubated, then you look at stroke volume. And if the stroke volume changes greater than 10% or a passive leg raise, changes greater than 10%, then give fluid. And if it doesn't and they're still hypotensive, you send them to the ICU to start pressors in the United States. If they're intubated, we try the SVV. Is it greater than 13%? Give fluid. All right. Does it change its stroke volume or the SVV goes down? Yes. Well, we probably need to repeat the step. If it doesn't and the SVV is below 13%, then we probably need to start pressors. This algorithm works very, very well. And then we have the contractility and the afterload algorithm that you'll see hopefully in a second. What we like to do in our institution is we do something called functional hemodynamics. And we put our Edwards screen on the map, so it's pressure and flow curve. And we put our areas between 60 and 70 and our cardiac output somewhere, depending on the patient, between 5 and 8, depending if they're septic. And this ball actually moves. And I'm going to actually play this right here. We're giving fluid right now. And so what we're going to do is you're going to see the ball move towards a lower cardiac output, and the patient needed fluid. And so with that, what we do is we allow the nurses to analyze the therapy that we give them. So we say they needed fluids, SVV was 15, the stroke volume was this. If I gave the fluids, does it help reduce the high cardiac output and the low MAP to a normal or function, or does it stay that way and we need to start pressors? You have to forgive me. I'm going to have to drink a little bit because I'm not used to talking this much in the days of COVID. This is actually another one where we had a 45-year-old male with septic shock on Levofed. He was given 12 liters positive, but he still was in acute renal failure, and his lactic acid was pretty high. Nobody wanted to give the guy fluids, but if you saw the ball right out here, his cardiac output was extremely high. And then his stroke volume was actually only 5 because he had so much ascites. But when we gave him some albumin, it actually drugged back in and lowered his cardiac output and improved his MAP, so his pressure and his flow curve came. This is how we use stroke volume variation, and cardiac output at our institution for functional hemodynamics, which is very useful. This has actually been around for a very long time. Arterial waveforms has actually been around with Hemophilus in the 3rd century BC, where they actually analyzed waveforms or pulsatile in Romans who were actually you could feel their pulse, and they measured that. All the way to Ludwig's, all the way into the nowadays where we have actually digital waveform analysis where we can do instant mathematics from the 2010s. So if we have done this for centuries and centuries non-invasively, can we do this non-invasively like we do for the minimally invasive, the arterial waveforms? And in actuality, this has been done for a great deal of time. And as I show this, it's been done very reliably, beat to beat, and that we can analyze cardiac output and changes in predictions of therapy with this. We can use protocols to guide fluid management. And really, to be honest with you, recent research shows that non-invasive hemodynamic can be used in every settings. We use it in our rapid response. Our hospital has 1.2 million square feet of real estate. We have like 4 towers. And so our rapid response goes throughout that for people who are hypotensive and in shock quite frequently. And to get a doctor and a nurse and an advanced provider there takes a little while. And so they have protocols that they start fluids and look at the responsiveness. This is actually one RRT case that I give you for its very example. We put the clear site on. This was a 67-year-old female who was hypotensive. They hadn't gotten 2 liters over the day, but they weren't really confident they needed more fluid. They just wanted to start pressors. The RRTs went to the bedside and found that the patient looked like they needed fluids, and they did a straight leg lift. It gave them that, and then they started, if you look, they started a liter bolus right here. and they had actually about 30% change in about 3.5 minutes. And it actually benefited this patient. Their lactic acid at that time was like 2.5, and it went down to 1. Patient remained on the floor, didn't have to come to the ICU, and didn't need an arterial line. So it was very useful. Our non-invasive clear site was extremely important. And what it did is it allowed us to give us a binary answer. Does that stroke volume change, like I said, greater than 10%? Or does it not? If they're still hypotensive, it doesn't change the stroke volume, then we know that we have to start them on pressors because they've been on that curve, and then we send them to the ICU. If it does change, then we give them more fluid and see if they improve their pressures. Sometimes, like in our study, we do have people who are resistant. They get eventually the second liter, they're still hypotensive, they don't improve their stroke volume, they come to the ICU. But it gives us a binary direction of, are they fluid responsive? Does their stroke volume change or does it not? And basically, sometimes patients are extremely complicated and we're not sure where they're going. And this is one case where we had a 45-year-old female with pulmonary hypotension, hypotensive, and was admitted for septic shock. They were given 2 liters, and basically they were started on Levophed, and the flow track was placed for hemodynamic monitoring because they had a minimally invasive. And as you notice, we did the same thing here, is that we tried to optimize them as best we could. That actually didn't work itself out because the patient was still hypotensive. If you look, the map was 66, and despite maximum Levophed, so we knew that the patient had pulmonary hypertension and possibly had ventricle decoupling. That challenge is that I talked about before, to where the right and the left ventricles are not optimized. And so what we did is we actually tried to optimize with a flow track and a CCO to try to give them the best ability. If you look down here, we saw their EDVI, which is extremely high for a right ventricular ejection fraction of 21, that they needed fluids. And even though it looked like in the previous slide that they were hypotensive and they probably needed fluids, we knew that their right side was dysynchronous. And so we decided that it was time to take fluids off and start CRT. The patient improved and went away. With that, arterial waveforms do have a limitation like we talked about. We know that they are on the left side of the body. The right side, which is about 65% of your vascular space, if your right ventricular is ventricle decoupling, then it's going to give you different errors. And so what I like to show on here is a 42-year-old male who had VFib arrest. And then we actually put in a Swan-Ganz catheter in the cath lab. And we thought at first, hey, our waveforms are dampened. We refloated the Swan. And we found that if you look, the arterial waveforms on day 1 compared to the right ventricular waveforms, right, were way off. Or pulmonary artery waveforms were way off. And they were muted. And so we knew at this point that this patient had something called ventricle decoupling. So the right did not equal the left. Our job over that time was to optimize the fluid management for the patient. And if you look now on day 3, you will see the positions of the pulmonary artery catheter have not changed, but you can see the difference between the waveforms. And you can see that there is actually a notch and a resistance to that, which gave us the ability to recouple the ventricles left and right and improve the patient's hemodynamic, wean them off of the pressors, and extubate the patient. And the patient actually walked away, which was extremely important. This brings up a topic, and once again, we have 45 minutes, so I feel bad because I like to talk about this for days, but we know that arterial waveforms are very, very important. And they're very useful to measure preload, afterload, and contractility. But as I could show you and built in the Non-invasive gives us a stroke volume change, which basically yes, no, does it change? If it doesn't change, we need to start a pressor and bring them to the ICU and probably escalate the hemodynamic monitoring to a minimally invasive and understand the contractility, the preload, and the afterload. And if that doesn't work, then we have ventricle decoupling where the right and left aren't working together, and we need to look at that. And we need to look at that term because most people believe Starling's law is Starling's law, but there is a ventricle interdependence, and that the optimal performance of the right ventricle controls the left ventricle. And so if you have volume overload or decreased right ventricle contractility, you basically do not get enough fluid back to the left ventricle. It decreases its performance, and thus it starts to decrease the left ventricle, which then decreases the right more, and it goes into a right ventricular failure spiral. And at that point, it's extremely important to optimize to a pulmonary artery catheter, and most likely to understand when to use a pulmonary arterial catheter for perfusion. With that being said, I like to always bring evidence or consensus-based, and this was actually one of the last consensus-based of when to use pulmonary arterial catheters. And ever since 2007, 2008, it was looked at that pulmonary catheters have gone the way of the dodo in the United States, bird. And with that, we actually started bringing back our pulmonary arterial catheters around 14, 16, when we knew that there were some very useful times for that. When we didn't understand the septic shock, or if they were in cardiogenic shock. And the American Heart Association, AHA, with the cardiogenic shock network, has really started to recommend, if you don't understand the cardiogenic shock, pulmonary catheters are useful to put in a PAPI score and calculate cardiac power at all time to understand whether you need to optimize that right ventricle. There's also is if you have pseudosepsis, if you have pulmonary hypertension, if you have transplant patients. These patients, we understand the ventricle decoupling is at very high risk. So there are different pulmonary catheters in this world. And so I like to say that, and I fortunately had the privilege when I was with Edwards for a while to meet the founders of the original pulmonary catheter. But that was actually way back when they did that was the 1970s and 80s. And so thermal dilution catheters, back when I started talking about this, you would shoot a cardiac index every 4 to 6 hours. But as I talked to you about earlier, that Maxine Cannison and his team really did start showing that hemodynamic measurements were extremely important. And that understanding your therapies by giving a therapy and understanding how your therapy changes actually benefits the patient other than just looking at the numbers every 6 hours. And so the continuous cardiac output, which has not got a lot of traction in the world, but is very, very important, allows us to start looking at continuous outputs and RVEF and EDVIs as you're doing the therapy. And so the 80s have called, and they really want their thermal dilution monitors back. But the most important is we have the ability to look at left and right, which I had that previous case, and understand if there is ventricle decoupling. And so who can use a pulmonary catheter? Well, in the standard catheters, you get a mixed venous sat, you get a thermal dilution, you can float a pacer in if you need to on catheters. But in advanced catheters, basically give you the ability to look at all the things that you looked at in the regular thermal dilution, right atrial and wedge pressures. But you also can look at continuous cardiac output. Are my therapies increasing or decreasing? Can I get contractility? Yes, right. And does it match closely as I change the right contractility? Does it help the left? What is my volume status, whether in the EDVI? And then how do I look at the volume status compared to my afterload? And with these, I can start more complexity of manipulating my numbers on those complex patients. Is there evidence that a right heart catheter is important? Well, there's the building evidence, and this actually was a study that I liked in 2017 that kind of took post-cardiac surgical patients. And there was a strong prediction in right heart failure that was unbeknownst to most of the researchers in the study until they started looking at low RVES, which is right ventricular ejection fraction, had a higher two-year mortality. And that was low RVES coming out of the OR immediately post-op. And they actually took the study was an echo versus CCO and found that the patients that they could contribute to improving their RVEF and improving their fluid afterload had a better chance of survival, and it went out to 2 years. And so this was an incredible study that started kind of building on the practice that if you think the patient has right heart failure, then probably most likely you're going to need to escalate your hemodynamic and optimize your perfusion with a pulmonary catheter to measure the right ventricular contractility. And so really these complex patients, it goes back to understanding, just like we talked about in the beginning of the lecture, and that is consumption versus delivery, and matching that is extremely important. And as I build this lecture and start talking about optimizing perfusion through hemodynamic monitoring, you can see that I've kind of built a non-invasive is in a place where you want a binary answer. Do I need to give them fluid, or is fluid too much that can harm the patient? To a minimally invasive, understanding how the dynamics work, and we understand that the left side and the right side are coherent or not working together, and we need to escalate to a pulmonary artery catheter. And this algorithm kind of just gives you, as you look at it, the ability to change your consumption, your perfusion, and look at it. So we've already kind of talked about who might need a pack, and I kind of gave you the European consensus in 2014, but we know that cardiogenic shock is probably what's going on in the world right now is the biggest player of getting a pulmonary artery catheter. Discordant right and left ventricle, I kind of beat that very, very much with this. Severe heart failure that's requiring inotrope to titrate. Pseudosepsis that we don't understand what's going on, whether it's septic shock or it's another form. Myocarditis, or pulmonary hypertension, things that we know that the right side is weak. And then basically complex patients like transplant patients. This is an example of understanding a CCO, and basically you're matching the volume with the contractility. So if you have an RVEF of 40, you know that your end-diastolic volume should be very low. And those numbers are usually about 80 to 120 for an RVF, about 35 to 40. And at critical ill, you're going to see it in the 150s, 160. As you decrease your right ventricular ejection fraction, you expect more fluid to remain in the right ventricle. There are diagrams like we talked about of, if somebody has 250 and I start diuresing them, I should improve my RVEF and I should reduce my right ventricular ejection fraction. And so understanding that contractility and volume in the right ventricle have a direct reflection. So if I have too much volume, if I reduce that volume with CRT or Lasix, I should improve my ejection fraction. And if I don't, then I might need inotropes in order to do that. Let's give a case, and I'll just talk about this real quick. So we have a 55-year-old male with congestive heart failure and an RVEF, or an EF on the echo of 35%. He comes in. If you look at his chest x-ray, it has extremely whited out. This actually happened overnight. One of my favorite cases because it was unexpectedly, he had no urine output. He looked like he was fluid overloaded. His lactic acid was high. Everybody in the room was like, we're going to give him 500 cc's bolus, and then we're going to send him up on pressors. If you look, he basically came in and he had, his sodium was low, his bicarb was 17, his creatinine was 2.4, which his normal was like 1.2, and his lactic acid was 5. And so we questioned whether this was cardiogenic shock or not. If you look over here, we had placed a arterial waveform in the ED, and it really wasn't giving us great information. Its SVV was 20, right? And its cardiac output was actually about 7.5. And so we decided that this is a complex patient, and we put them a CCO in them, and we kept the flow track in. And so what we did is when we saw the CCO, we saw that its SpO2, so his consumption, which should be greater than 70, was 59, right? You know, we wanted 65, and that his cardiac output was low, and his RVEF was 35. And then we started looking at the EDVI with this should be somewhat about 110. And if they were critically ill, it should be in the 180s, like we talked about. And so we gave a fluid bolus, even though that chest x-ray looked horrible. His RVEF stayed about the same. His EDVI went up, but his SvO2 was it went up from 59 to 68. So it was just right there, but his cardiac output was still low. If you look, that SVV went down to 12 from 20, and his cardiac output just still stayed on the EDVI. It was like 2 off on the flow track compared to the CCO. And so we decided to start inotropes. We started debuting. That way, he started pulling CRRT. We were able to pull fluid off of him, optimize him. His levofed decreased, and then we were able to actually wean everything off. And this is what it looks like. His RVEF came back to its original, somewhere around that 35. His cardiac output, if you notice, went up to 4.4. His SvO2 was really nice. And if you look at the numbers over here, everything started looking normal. So we started weaning off the levofed, got extubated, and he actually left the hospital. Really good success story, but it showed in an example of the escalation of ED to where, you know, we didn't have a clear sight on him, but we automatically knew that we needed minimally invasive monitoring. That was not enough, and we escalated to pulmonary catheter, continuous cardiac output. So kind of trying to talk about the truths. Well, hemodynamic monitoring truths. There is no normal cardiac output, and so trying to monitor using hemodynamics to make numbers normal is kind of useless. You have to have a goal to treatment, and it has to be individualized physiological requirements. So you use hemodynamic monitoring for the goal of treatment, not just to use it. Functional hemodynamics, such as what we talked about earlier with Maxine Cannison, and then you saw how we took that into our pressure and flow, where our nurses are able to look at it every minute as we're changing our therapies, are extremely important. And it allows you to not only monitor, but see your therapy change, demonstrated before. And then once again, there is no monitoring device, no matter how simple or complex, whether it's an arterial line, whether it's minimally invasive flow track, whether it's maximally invasive pulmonary arterial catheter, or in between our are, a flow track that gives you that allows us any accuracy unless it's coupled with the treatment. And that shows you what our treatment therapies are doing. Is it improving the patient's hemodynamics or is it making it worse? So with that, I think I'm right on right on the 45-minute time frame. I will take any questions you have.
Okay, I think thank you, Dr. Charles Huntley's excellent lecture. I think there are no any question posted, but maybe I can add some question, have a dialogue with Dr. Huntley. So I just ask a simple question because from the previous study, the PEC, they try to do the clinical trial, but it turned out that didn't change the outcome of the patient in general. But I think is any kind of study, as you know, that compare with invasive hemodynamic monitoring versus we use a conventional way, try to compare these two methods, is really do a clinical benefit by using the invasive hemodynamic monitoring to improve patient outcome. Did you know any kind of clinical study? Sorry, can you the sound is muted.
Got muted again.
Yeah, right. Okay.
Can you hear me now?
Yeah, we can hear you.
Okay. So no, there actually, ever since, you're right, since the PAC study, there really has not been a counter. And if you think about it, I joke around. Usually I have a slide that looks at the development of iPhones compared to hemodynamic monitoring. Of what, when we had the PAC study, we had the original flip phone, which was like the chocolate, I think, in the United States. And now we have iPhones, which have come a whole long ways. We have not done that study. And it really is, I think it's a cultural thing, to be honest with you. Now, the American Heart Association with cardiogenic shock has done multiple studies with pulmonary catheters of how they're useful, but not a head-to-head comparison. My personal opinion is that if you can do a minimally invasive hemodynamic monitoring and the patient doesn't have ventricle decoupling, then you don't need a pulmonary arterial catheter. And that makes sense in the sense that if you're using for minimally invasive, which means you think that you are going to be able to manipulate the hemodynamics from the arterial waveform and that you don't have a right heart problem, then you shouldn't need a pulmonary arterial catheter.
Okay, and I think another question is I think we manage the patient, try to assessment by hemodynamic monitoring. They will do some action and should be some outcome. Then I know showing from your slide, but is any kind of more intermediate outcome? I mean, any kind of, for example, biomarker or something to show you, okay, you are doing the right way, and show, okay, this assessment, action, and outcome, it fits the trend of the patient improving. So I don't know, do you suggest more frequent measure, for example, the lactate or something to show, okay, everything is on the right track to convince ourselves, okay, I need to do, keep going, do the same way.
So you have a great point, and I'm going to take back to one of my, he's actually a friend of mine and a mentor, and you guys have all know Manny Rivers' sepsis guidelines. So biomarkers with, first off, if you're in horrible septic shock and your troponins are increased, you need to follow those biomarkers because we know that increased troponins have an increased mortality in septic shock. Lactic acid gives you a global look at it that we are resuscitating. But if you remember, like so we started hemodynamic monitoring if the patient, and I'm going to use septic shock because it's one of the number one reasons we use hemodynamic monitoring. We put a hemodynamic monitor, we assess the volume we give them, and we assume to this day, and there are studies now that show that we shouldn't assume with lactate clearance in Europe, but we assume that if we give them and resuscitate them, their lactate clears. And so that's where we check our lactic acid. In our institution, we'll resuscitate and check it in 2 hours, right? And then frequently check it to make sure that it's not getting worse. That's one of our major biomarkers in the United States. In Europe, I know that I've had multiple colleagues that we debate that, whether lactate clearance is significant or not, or is it just diluting the pollution? That's a biomarker we use.
So how about capillary refilling time? Do you think it's useful or many confounder to assess this?
Say that again. I'm sorry, I missed.
I mean the capillary refilling time to look at the capillary
I do actually. I think capillary refill time is actually extremely important. I mean, you see a patient that has, and basically that's our basic hemodynamic monitor. Are they look cold? Are their extremities cold? What's their capillary refill? As I give fluid, and actually the non-invasive monitoring, if you don't have a capillary refill time, half the time it doesn't work. And people want to throw the cuff out and say, it doesn't work. You're like, you have to resuscitate the patient. The cap refill, they're so down. So it's extremely useful.
Okay. And I think another question I was wondering, because you know that some acronym means ROSE, means resuscitation, optimization, stabilization, and evacuation.
I actually, that is ROSCE, resuscitation should be within minutes. Optimization should be within hours. Stabilization should be within days. And then there's a de-escalation. I actually have that in a lot of my other slides. I talk about the ROSCE, extremely important. And when to use fluid management is during that resuscitation phase, which should be, you shouldn't need a hemodynamic monitoring to assess your resuscitation over a long period of time.
So I mean, during the stabilization or a special evacuation, do you suggest still need for in certain circumstances use the hemodynamic monitoring to do okay? I'm for a stabilization or evacuation stage. Can you use it or?
I do in patients, and I'll give a good example. I personally use the optimization stage. Because I know that there are ebbs, the term ebbs and flows of the patient, where they continue to kind of stabilize and decompensate. I actually use it to not give fluids as much because a lot of people in the United States in the middle of the night, they'll call one of my residents and they'll say the patient's hypotensive. They'll give a liter of fluid. And that patient starts to become 3, 4, 5, 6 liters positive, and that's actually detrimental for the patient. And so if they're going through those ebbs and flows in that stabilization phase, I keep the hemodynamic monitoring on. Usually, unless we're doing CRRT or renal therapy, I usually take it off for de-escalation because they're already past that.
And I think a more complicated situation, for example, patient on ECMO. So in that circumstance, how do you use this kind of hemodynamic monitoring to, I think more complicated because the volume of devices. So do you suggest how to use this device under the ECMO situation?
Wow, that actually, I just used, I did a presentation, and I don't know, where I gave a case series where I did ECMO on a VV ECMO. And I use it actually on venous ECMO tremendously. Our VA ECMO, because of the non-pulsatility of VA ECMO, I do not. I actually use a Swan on those patients. But on VV ECMO, optimization of fluid management is extremely important. The COVID patients, we know we want to keep them dry, but not too dry. And if we're using ECMO on them, you don't want the ECMO machine to fight against, the patient for being too dry or too wet.
So you would highly suggest for the VV ECMO patient, but I think some argue because so many confounder, because of cubing, etc. So how do you really know how to manage with that? Yeah.
So I actually do the functional hemodynamics. So I will put the pressure and the flow, and it allows me to look at the volume, to look at the patient's, for example, if the patient's heart or blood pressure is extremely high and their cardiac output's high, they need sedation. And so we titrate our sedation off of that a little to bring them back into kind of the normal hemodynamics. So our ECMO doesn't fight the high cardiac output. We also use it for fluid management. Do they need fluid? When they start to, we call it in the United States, chugging or tugging on the tubing because of dryness. And then we use it for, we actually use the functional hemodynamics to take fluid off on CRT, because usually your MAPs are high, your cardiac output's low, and then we take fluid off to drag it towards a normal cardiac output.
Okay, I think there's some question posted. It means that in case of low cardiac output, should I further titrate vessel pressure dosage, even at already at higher doses? Is any reference range I can titrate my vessel pressure to? How much higher dosage can I use it?
So we actually, so vasopressins, such as Levophed, is what we use in the United States. We try not to titrate. We actually try to do megs per kilogram. So, like after one in our institution, you can go as high as you want, but there is a diminishing marginal return and you start to have ischemic limbs. And so what we do is, if you are resuscitating, and I personally am a VAS2 study believer. If you're titrating your Levophed up, we usually add in our institution vasopressin, right? Which, there's controversy about the VAS1 and VAS2 studies, but then we'll add in vasopressin, and we try not to go more than 1 megs per kilogram, mics per kilogram per minute on our Levophed, but you can take it higher. It's going to have ischemic limbs and a high risk of ischemic gut. And so what we try to do is we try to limit that to 1 mics per keg per minute. So.
Okay. Another, I think it's a little bit practical question. The audience asked about PICO versus flow track. Then do you suggest comparison these two devices? Which one's better or equal or any kind of?
So it's funny because, and I'm not going to comment because there really is no head-to-head study on each one. They compare each other, PICO, and I've used PICO and LITCO, and PICO, really the extravascular lung water is really important in those patients, and it's been studied a lot in Europe with ARDS. Actually, Edwards has extravascular lung water system that they have. So PICO and LITCO are both PPV and SVV are very comparable. Practicality, PICO, the injection, getting the injection, doing the injection tends to be more labor intensive to me. There is no studies, the head-to-head comparison. I've used them both extensively in the translational lab environment and in human medicine.
I think, do you think PICO, because they can do the thermal dilution to calibrate then monitor again. So for the validity, is there any more better for the PICO to calibration on a regular way? Do you think it's okay?
I like the thermal dilution calibration with PICO. The practicality, what I mean by the practicality is unless you're I'm trying to say it in a nice way. I used to do a research study where I would resuscitate large animals, swine animals, to do a sepsis project. And it had nothing to do with actually comparing flow track to comparing PICO. So pulse wave analysis to pulse wave. It just, we tried to calibrate. We'd calibrate it, it would lose it. We'd calibrate it, it would lose it. We decided not to go with PICO, and this was 2007, only because it was just labor intensive for us. But the calibration is good, and if you like LIDCO, they also have it. It's a lithium calibration, which kind of is a pain too. So.
Okay, I think there's no further question, but I want to ask a last question. It's on my mind. I think, do you think the trend of our resuscitation of critical ill patient, I look at there's some trend about more earlier use of the pressor. I mean, not under the very adequate free status. Instead of that, but they try to use earlier of the vessel pressure. Do you think this kind of trend of management is okay, or any comment about this therapy?
So that's actually a really super good question, because and I'm partly to blame for it, because we just put a very large paper out that talked about fluid management perioperatively, and that there's an optimal state for it, and there's a direct reflection on mortality and organ dysfunction. We just talked about Benet's Roski outlet, right? And we started talking about the resuscitation. Most shocks, other than, most shocks when we start in the United States use ATLS, the trauma shocks, or ENLS, the neurological life support. The resuscitation with fluids is always the start of the mainstay. We are kind of drifting away from that in septic shock and cardiogenic shock. I'm not sure yet. I think the data in the next 3 to 4 to 5 years will show us, because there are studies that says early pressors, and there's some studies that are out of Vanderbilt, and there's some studies in the United States that I'm curiously waiting to see. I still resuscitate my patients very quickly, and as soon as they stop needing fluids, I go to pressors. Probably earlier, just because it's that early resuscitation process, but I know that I have several of my colleagues that start pressors a lot earlier, and we're all kind of waiting for that study to come out. Very much similar to the isotonic versus, normal saline versus lactate ringer study that came out a couple of years ago that kind of gave us that answer.
Yeah, okay. So I think it's very important. I think today, Dr. Charles Huntley gave us a very excellent lecture, and we have about talking about the issue. Maybe some issue remain to resolve in the future. But I think for the common practice or intensivist, it's very important. Try to look at the patient, try to resuscitate, and maybe globally or microscopically, I think it's very important. And I think before I closing the session, I think the Chia has a little bit some survey want to do, so I leave the time to the Chia.
Yeah. Thank you, Dr. Koo. Thank you, Dr. Huntley. Thank you for your time. I just have one last survey I want to run. Is for us to evaluate how we've been structuring our webinars. So like before, please either you scan the QR code on the screen, or James will push out the link on the chat. If you can help us answer the question, that would be really appreciated. Please make sure enter your email address when you answer the question. For those of people who answer the question, we will send you a copy of today's presentation as a appreciation. So thank you very much for your time. Please help us to give some feedbacks. Thank you.
So I think today we have a very great talk. Even on the Saturday, I think everybody got much more information how to manage the patient and how to, I think, assess the patient and try to give a rapid response, correct measurement, and I think the outcome is very important. I think Dr. Charles Honey gave a very excellent talk and some thoughts maybe remain for us how to look detail how to measure a patient. So I think I have to close the section, and I think I thank you, Dr. Honey, to join this. So let's end the session, right? Okay. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.